Everyone. We are grateful to invite you all for today's session. I'm Alexander Bogo. I'll be your moderator. With me here, I have our presenter today, Agri Achoka, together also with Eric. We are happy to share with you some knowledge and skills in nutrition forecast examination, which is a part of nutrition care process. Maybe a little bit of background on why this topic is important is that for a nutritionist to be able to perform duties within clinical setting, good understanding of nutrition care process is very important. We all know that embracing nutrition care process is associated with effective, safe, and high nutrition care provision. And globally, there has been more of advocacy to embrace nutrition care process, improve documentation, so that we can see that we achieve all these objectives. Nutrition focused physical examination is a component that formerly was referred to as a clinical assessment, but following some milestone in terms of NCP development, we have 5 components of nutrition care process rather than 4. Initially, we had anthropometric assessment, biochemical assessment, dietary assessment, and the last one was what we call sorry, I'm almost forgetting what we call a clinical assessment. So for the in terms of new developments, we have 5 components, and these components, as you can see, is that they are more detailed. We have client history, we have food nutrition related history. Instead of biochemical data alone, we have biochemical data, medical tests, and procedures. And instead of what we called used to call clinical assessment, it's now what we call nutrition focused physical examination. So our topic today will shed more light. We'll discuss. We have more of interaction on this component because it's very key to understand it in terms of nutrition assessment. Because we all know that once we fail to do proper profiling of the patient during nutrition assessment, we might miss important data that will be useful when it comes to designing nutrition diagnosis. So I want to once again to invite you for this session, and you'll note your questions down. We'll be able to respond to all your questions. Thank you very much. So I want to welcome our presenter to take us through. He is very experienced in clinical nutrition, critical care, and particularly in these components of the day in terms of nutrition care process that we are going to discuss. Thank you.
Well, welcome everyone to the discussion today, or the webinar today on nutrition focused physical examination, which we'll go through to see what nutrition focused physical examination is all about. And we'd want for us to understand, to be able to understand well, of which it's a component of the process, as Alexander has alluded. He's already taken us through what it is all about. And the learning of outcomes that we want to do is more understand the reason why we need to perform nutrition focused physical examination. And probably how do we conduct this in order for us to be able to apply and assess, to apply the assessment tools which are valid and reliable in a reliable way. just to start off, it's just more of a summary of what Alexander was talking about in terms of the nutrition care process, which has 4 components that deals with the nutrition assessment, there's the diagnosis, be it the intervention, and nutrition monitoring and evaluation. Of which the genesis was way back in 2003 when it was adopted internationally. And in 2005, we generally had an introduction of the standardized terminology, which were describing nutrition diagnosis, which is now forms a part of the PES statement that we normally write. And in 2006, they released a second book that included the nutrition diagnosis and intervention terminology. And later on in 2007, they launched the International Dietetics and Nutrition Terminology Reference Manual, which is available online and be able to go through it. Looking at the nutrition care process. So today, we are going to focus more on the nutrition assessment. We are going to run this webinar more of like a series, and we're starting the nutrition assessment bit with a key focus on the client history. No, the key focus on nutrition focused physical examination. And perhaps I would want to request we do a poll. We see in terms of which is usually the first step in nutrition assessment. So probably we can put up the poll and see how people are going to respond to it and be able to get a feel. Where do you feel we need to start our nutrition assessment? So if you can have the first poll. So perhaps as you are waiting for the poll to come on, so you already said you're going to have this more of a series. So you're going to start nutrition assessment and later on proceed on until we are able to complete the whole nutrition care process. And perhaps in the later in the later sessions, if we are going to have more of a case study presentation after we are done with the nutrition care process, so that we can be able to apply all the knowledge that we'll have already gotten from the first presentation to the second, third, and the fourth, which will be running as a series. So with the fourth one, we expect it to be more of a case presentation to apply the knowledge that we have already gained. So with the poll, I don't know whether everybody has been able to answer the poll question in terms of we were looking at which is the first step in nutrition assessment. So that's what I needed people to poll on and to be able to tell us. There it is. So you can choose. So what do you think is the first step in nutrition assessment? What should you do first? Well, I can see the results are coming in. So I'll give the next 10 seconds for people to respond to it. Then I can be able to see. So we can end the poll, I believe, so that we can see what the response is. So as you can see, we have 23% saying we should be looking at anthropometry as the first step. We have quite a number, 3% who are indicating biochemical data, and the majority are indicating the client history at 46%. And when it comes now to the dietary bit, we have another one saying 21% feel like dietary history should come before any other form of assessment. 16% are for the idea of the topic of the day, that is nutrition focused physical examination. And we have 2% who are saying they have no clue at all. So looking at it critically. So we have these 5 categories when it comes to nutrition assessment categories, which are classified as either client history, we have nutrition focused physical examination, food nutrition related history, anthropometric, and biochemical data, together with the medical procedures and tests. So in the first, you have to look at, before you even initiate the assessment, definitely you've got to have a brief introduction about the client you're seeing, because it is hardly you'd go to an individual just come to you and then you just decide and say, okay, let's just do that. And you don't even know the name of the patient or the client that you have. You don't even know the age. You don't know why are they even in your office? Why have they decided to seek your professional advice? So as you can see, I believe the client history should always be the first thing we ever do in our nutrition assessment, because in the client history, it helps us to set a context to the other forms of assessment and can aid in determining the appropriate equipment probably that we need to use. And it encompasses the patient's biodata, such as the name of the patient you're dealing with, what's the age, the occupation, what is the family social history, are they married, are they single, where do they live, do they even have children? In terms of, even if it's about child spacing, you'd want also to know. We'd also want to know what is the past medical history of this patient. Why are they even seeking for your advice? What is it that is ailing them in the first place? Have they had prior admissions before? Have they had a similar problem before? That's why probably they've been referred to you. And is there a difference? Is there any in terms of the socioeconomic status? Are they currently working, not working? So that can be able to preempt in terms of how should your management go. So the most important thing here is client history or information collected is usually systematic, and the evaluation of the nutrient status is usually based on the overall data that you collect. So after collecting the client history, that's where now you move on into the nutrition focused physical examination, of which it usually has 4 components, which are usually borrowed from the medical practice, whereby the first one you'll have, there are usually 4, which they are more like techniques of how to conduct the nutrition focused physical examination on a patient, of which mostly the first and the second is what is usually used, but the third and the fourth, we hardly practice it in nutrition focused physical examination, of which inspection is usually more of observation, using your sight and your senses in terms of you're looking at, are there any color changes? What is the texture of what you're looking at? What is the size? Is there a presence of edema? What is the behavior like in terms of the nonverbal communication from the patient? Is he grimacing whenever you're having a conversation with the patient? Can he actually even be able to speak for himself or not? So those are things you can be able to inspect. Those are things you can be able to see using your own eyes. And then there's the other bit of palpation, which is usually more of a physical examination by touching, so that you're able to feel the pulsation vibrations, to look at the texture, size, tenderness, temperature, or presence of edema. You see, whenever you're looking for edema, you'll have definitely to touch the patient, to press to determine what is the grading of the edema in this particular patient. So it becomes very, very important for us to look. So with this, we want to say the NFPE usually elicits any abnormality, and it's the most used technique in NFPE is usually the inspection and the palpation bit. And the third and fourth, I've already said, not really hardly, we use it lesser, and it's less commonly used. So the role of nutrition focused physical examination, as you can see, is to probably be able to elicit the subcutaneous body fat loss, muscle wasting, there's the fluid status, nutrient deficiency, and perhaps also the functional status. By functional status, meaning in terms of, are you able to elicit whether your patient is ambulant or non-ambulant? And in the actual sense, can they actually eat with or without assistance? You also examine the strength of the extremities. Are they able to sit up? Are they able to even stand? So that even as you're looking into the other forms of assessment, can be able to decide on, would a weighing scale be appropriate for you to tell a patient probably who is not able even to sit up for you to be able to weigh. So as you can see, the nutrition focused physical examination also determines the nature of equipment that you'd want to use, or even the subsequent assessment that you'd want to do to the patient, of which I'd want to put up now the second poll, of which it's all about which the following forms forms part of the NFP, except which one. So choose the one you feel is not part of the nutrition focused physical examination, and we'll spend like 40 seconds for people to poll to see. I can see people have quite a number have already polled. It's quite interesting from whatever we're seeing from my end. We'll be able to share once we end the poll and get a feel of what people are saying in terms of what is not part of the nutrition focused physical examination. That's what the question is asking. Is it something to do with the hair or the head? Is it about the skin, eye, weight, oral cavity, the nail? So perhaps you can end the poll and share the results. So as you can see from your screens, we still have quite a number of disparities in terms of what nutrition focused physical examination is all about, of which I can see quite a good number have gotten it right, of which weight is not part of the nutrition focused physical examination. It is part of the anthropometry. So for the ones who are saying the head, hair, skin, the eye, oral cavity, and nail are not part of the NFP, as you can see, they form part of the nutrition focused physical examination as we continue on in our subsequent, as we continue on with the presentation. So if you're to look at the focal key areas of examination, you look at now the areas that you want to be examining are the head, whereby you focus even also on the neck, the eyes, the oral cavity, the tongue. There's the aspect of the skin, the chest wall, the clavicle, the mid-axillary line, plus also the lower extremities, that is the lower limbs also. You'd want also to focus more on it, because in this bit, you want now to do it now, you begin with the inspection. What actually can you be able to see? Let's say, for example, you're inspecting the scalp of the patient. Can you be able to elicit a previous surgical scar on the head? Probably had a head injury before that you'd want to know what happened, the preemptive, so that you can be able to get the history from it. And from that, you can be able to see, you're able to build more information on what to do. Plus, the other thing is the list is not really exhaustive as per what I've already shown there. So it's quite important for us also to look at, perhaps when you're even looking at the skin of the patient, you want to look whether it is intact or you're having pressure sores on your patient. And also, as you're doing now your examination or inspection, perhaps the patient has already undergone a major surgery and he's having a stoma. And you see, whenever he's wearing his clothes, it is hiding that stoma, which you cannot be able to see until you're able to examine the patient. Is there a peg, for example? Patient is using a subcutaneous endoscopic gastroscopy tube for feeding, and then now you won't now be able to jump to the conclusion that the patient is just feeding orally. At least from that end, you'll be able to say, I can clearly see there is a different mode of feeding this particular patient. So it sets the mood for the intervention that you're going to discuss with the patient. And perhaps in terms of identifying muscle and fat loss, as that diagram is indicating, for muscle, you want to focus on the temporal, for muscle wasting, the orbital, fat pads, the clavicle region for both fat and muscle wasting. And as we move on now, we'd want now to go one by one in terms of whenever we are discussing now the subcutaneous body fat loss, you'd want to assess the fat loss in three key main areas, of which the first one is usually the orbital fat pads. So you'd want to elicit in this particular pictorial, as you can see on the left here, you can clearly see where the fat deposition is usually at. And as you're losing now your fat, you can see clearly what when you're losing fat loss. So now you end up, whenever someone is having sort of like a severe malnutrition, you'll tend to have more, they tend to look more hollow in this particular area. And there'll be more of a depression and dark circles with loose skin, as you can see on this pictorial on my right. If you can compare the left in terms of the skin, how the skin would look like, and the right one, as you're losing the fat, you get now there's a fat loss in that particular area. Moving on, if you have to look at also this particular picture, now we are focusing more on the thoracic and the lumbar region. That is more of the rib cage and the lower back, as you can clearly see from this particular image here. As you can see from this particular image, you'll get around this particular area, the clavicle. You can see it's so prominent in that you can't miss that out. So there's it's so prominent in terms of the fat loss, even in terms of the between the ribs. You can clearly see there are more spacing. You can actually count the ribs in this particular patient on this image. Even from the back side, you can clearly see in terms of there are depressions between the ribs, which are very apparent. And here at the iliac crest, you can clearly see it's so prominent, and it is indicating there is some fat loss in this particular patient. Moving on to the muscle wasting. When you come to the muscle wasting, you want to look at the temporal. The temporal is this particular region here, and you'd want to inspect and palpate that particular region to get a feel in terms of how the muscle there are feeling. And then in severe cases, you get like they form more of hollow. There's hollowing and scooping depression on the temporal region. And in mind, you get like there's a slight depression, but in well-nourished patients, you get a feel of it is well-defined and the muscle will be a bit more firm. Moving to the clavicle region now, you'll get to see in terms of this is the clavicle region. The clavicle becomes very prominent, indicating some muscle wasting around this particular region from that pictorial. And then I'm looking at the second one on my right. If you were to look at this particular where the laser pointer is pointing, it's indicating that's now the acromion bone. The acromion bone region, you usually get it becomes more prominent, and that's between now the shoulder and the arm joint. And then it is more protruding and becomes more of a square-like. From this end, it's supposed to be more rounded. You're not able to see all the bones from that particular area or region. Looking back at now the scapular region, you'll be able to visibly see in terms of the prominence. The scapula is so prominent, you can't be able to miss it. Whenever a patient is having now the severe, and then there's a visible bones which can clearly be able to see and elicit. And whenever you're looking now at this particular picture, you can clearly even see from the back here, you can be able to see now the depressions that we are talking about. So the scapula becomes more prominent, visible bones, and depressions in between the scapula, and also in terms of the shoulder and spine, as you can see from this particular image. When you're looking now at the muscle loss on the lower extremities, I believe for those who are practicing in the clinical areas, this picture, you can clearly be able to say at one particular point in time in your practice, you've had such a visual picture, which is trying to illustrate in terms of whenever you're looking at the anterior thighs, this bit here, and in your quadriceps, there's more of a depression line on the thigh, which is obviously very thin. And when you're trying to look at now the calf, you'll see it is very thin, minimal to no muscle definition at all on this particular diagrammatic presentation. Now into the third bit, whenever we want to look now into how do we assess for edema in the patient? How do we want to look at now the fluid status in a particular patient? And we probably can put up our last poll in terms of how do you grade the edema? Which are the various ways of how you can be able to grade the edema. So we can put up the third poll. This is now the last poll we'll be having to be able to see what exactly we'll be able to elicit. So if you can have the third poll. So as we're waiting for the third poll to come up, in that particular, this particular picture, as you can see, this patient, you can clearly be able to see most of the things in terms of the prominence of the muscle mass loss in this particular patient, and this becomes more of a severe form of malnutrition in this particular patient. And whenever you encounter such, you'd want to clearly want to look at now what are the precipitating factors that would put a patient or put a client to have more of a to appear this, so that if you're doing now the root cause analysis in terms of what is causing muscle loss, you'd be able now to be able to assist the patient rather than just intervening and providing more of a just short-term intervention for the patient. You'd rather want to look at the long-term intervention, and I can be able to see there is the third point whereby you're looking at an assessment of a finding of +2 pitting edema would characteristically be described as what in terms of the duration of pitting. Is it a duration of pitting of 16 to 30 seconds? Would you want to say it's a duration of pitting of less than 15 seconds? Would you say it is a pitting of more than 60 seconds? Is it 31 to 60 seconds? Is it a duration of 5 to 10 seconds? And here you can clearly be able to see there's also some bit of mixed reactions in this particular poll. We'll have like another 30 seconds to allow people to poll and see what exactly, how would you be able to grade a +2 pitting edema for the patient that you're having in terms of the duration. So probably we can end the poll and be able to see from there on. So as you can be able to see, we can share the results. We can end the poll so that we share the results so that people can be able to see the feeling within the room of the presentation. So you can see 30% are saying it's more of a duration pitting of 16 to 30 seconds. Quite a good number. The ones which is falling 30% is the 5 to 10 seconds. Then we have less than 15 seconds, other 60. So moving on, whenever it comes to now fluid status, you'd want to focus more on where would you want to look for this particular fluid in terms of edema. So you'd want to look at the face, you'd want to look at the neck, you'd want to look at the hands, the feet, the ankle, perhaps the abdomen also, and the certain region. And for you, it is mostly based on now the technique of inspection and the palpation bit, whereby you'll have definitely to palpate by applying pressure using your index finger to a bony prominence for approximately 5 seconds. Then you release and examine for the remaining pitting and the duration for the refill. And as you can see from that table there, so you can be able to gauge who guessed it right or who are sure in terms of +2, what is the duration of pitting that you expect to be. And in this one, you can clearly see in terms of edema can be able to pass the weight loss or falsely increase the weight of a patient. And in addition, it interferes with the ability to assess the muscle and fat loss also. So as you can see, whenever you're focusing on the initial focus physical examination on your client, it has an implication in terms of what next, where next in terms of your assessment. It is not more of, I just need to do everything. It becomes easier for you to be able to interpret the results of your findings whenever you're now dealing with this particular patient, as opposed to just doing an assessment for the sake of doing, since you need to do it. So whatever information you're gathering helps you to think ahead in terms of what next that you'd want to do. The fourth thing, which is usually the micronutrient deficiencies, and in this particular one, it is usually a very broad one, and you'd want to assess by inspecting and observe, which is more or less observing and palpating. You want to look at now the scalp, the hair, the skin, the nails, the oral cavity, the eyes, just to elicit, are you able to look for, what are you actually looking for? Are you able to actively look for these deficiencies that you want to look at? Because in particular deficiencies, you'd want to observe critically the patient. You'd want to look at what is the texture of the hair, what is the color of the hair, what is the distribution of the hair on the scalp of the patient, what is the shape and symmetry of the scalp. We talked about, and in that you're trying to assess the appearance. And whenever you're having that sort of like a dry hair, you want to think of something like vitamin A or E deficiency. Or whenever you're having a brittle hair, it's more of biotin deficiency. Moving on to the skin, you should be, whenever you're looking at the skin, it should be cool to touch, uniform in color, and symmetrical. And then out there, you'd want to also look at now, what is the color change in the skin? Are there any changes to the color changes to the skin? Is there a change in terms of the texture of the skin? You want to elicit temperature. Is the patient having a fever that can be able to pick on touching the patient? The skin, would you be able to elicit any wounds on the particulars on the skin of the patient? What is the hydration status of the patient by doing the skin tagger? Is the skin moist or dry? So that now you can be able to determine which particular end are you going to think of in terms of your micronutrient deficiencies you'd want to focus on this particular patient. Whenever it comes now to the nails, the nails actually should be symmetrical and smooth. Also, you'd want to look at the color, the texture, the strength, and the capillary refill in the patient. Whenever you're having like transverse lines on the nails of the patient, you'd want to think of protein or a zinc deficiency in this particular patient, or perhaps hyperkalemia. Other times it can be also due to trauma. Whenever you're having flaky nails, you want to think of things like selenium, magnesium, or biotin deficiency in the patient. When it comes down to the eyes, you do generally want to look at the appearance. Are there any spots like the Bitot spots, which usually are foamish, grayish, whitish lesions in the cornea, which would point towards vitamin A deficiency. And perhaps whenever you even certain things would predispose someone to those having those Bitot spots, like in chronic alcoholism or fat malabsorption, whereby vitamin A is not absorption of vitamin A is impaired because of the fat malabsorption in the patient. And in cases like in short bowel syndrome, that's why you're likely to get patients who are having things like the Bitot spots. Under the oral cavity, you definitely want to focus on how the lips are, the tongue, the gums, the teeth. Is the patient having dentures, for example? Does he have all the teeth? And with that, you can be able to pick in terms of what goes on with a particular patient, even in terms of intervention, which direction should you be able to take, so that now, whenever you're recommending a care plan, you'll have already focused more on how your plan is going to work moving forward. And that you'll be able now to be able to see in terms of whenever it comes to now to the things like the nail, you want to elicit things like spooning, clubbing, the color, there are hemorrhages, spots on the nails, and all those things. In terms of the extremities also, which is not part of this. But whenever you're even looking at the extremities, at times you want to look at the discoloration of the skin. Is there bruising, red alarms, flaking, all those are in terms of your assessment. So I have a table here which is more summarizing in terms of now the deficiencies you'd want to be thinking of whenever now you're doing in terms of you're doing micronutrient deficiencies in these patients that you're having. So whenever it comes to hair, as you're looking at now the lackluster and the change in color, you'd want to be looking at things of like selenium, magnesium, B12 deficiency. Whenever you're having thin and sparse hair, as in the case of patients who are having protein energy malnutrition, those are now the key things you'd want to look at: the iron, the zinc, biotin. Whenever you're having plaque hair, which gives you more of you're able to pluck the hair without pain in a patient, and the hair looks dull and dry, or is having more of a corkscrew hair. For corkscrew, you'd want to think of vitamin C. For plucking, you'd want to think of essential fatty acid deficiency and protein deficiency. However, you realize even in there are other non-nutritional causes of these changes or these signs in the patient. Like for example, whenever you're having like easily plucking hair without pain, perhaps if you're dealing with a lady, you'd want to find out whether they've been putting chemical in the hair as for the ladies, so it can be part of what is causing the hair to become plucky, but not really a nutritional deficiency. So it does not really indicate like all these signs is just nutritional deficiencies which are causing them. There are other non-nutritional causes which would perhaps feature in whenever you're having to look into the deficiencies of the micronutrients. When you go to the oral cavity, whenever you're having angular stomatitis, you'd want to think of niacin, iron, riboflavin, B6B12 deficiency, or perhaps it can be as a result of vitamin A toxicity also. And then now, when it comes to this angular stomatitis, there are nutritional things would be probably, if a patient is using dentures, he might be having ill-fitted dentures, or perhaps herpes, which would give you a same picture of angular stomatitis. If you're having more of a swollen, easily bleeding gums, that is gingivitis. Think of vitamin C, niacin, folate, zinc, or perhaps also vitamin A deficiency. And another key thing, which is not nutritional, it would be probably poor oral hygiene, might be something. Or if your patient is someone who used to smoke, perhaps, or someone who used to chew tobacco, you see, it can also give you gingivitis in a patient. If a patient is probably having dysgeusia, which is more of taste changes, high on your list should be about the zinc deficiency. And sometimes also some medications will give you taste alterations in patients. So it is not more of nutritional deficiency alone. Also think of broadly in terms of what might be causing. And now, when it comes down to the skin, if you're having a patient who's having pressure sores, which are taking quite a long time to heal, and they are forming more of rounded edges, they are rounding in along the edges, you'd want to think about zinc, vitamin C, and protein deficiency. And in that particular area, you'd also look at medications such as steroids, which would affect healing in terms of the wounds. You'd also want to think about poorly controlled diabetes in a patient who's having a wound which is slow, not healing so well. Sometimes it's also just poor skin care or infection, simply. Whenever you're having small hemorrhages under the skin, that is part of key, which is red spots on the skin, you want to think more of vitamin C or vitamin K deficiency in those kind of patients. And perhaps you can also think of probably the patient is on anticoagulants therapy. So it is an nutritional thing, but it might give you that such a thing, or it can be having abnormal blood clotting in a patient because of the therapy the patient is particularly getting. Yellow pigmentation, we want to think of the B12 deficiency, perhaps, or the patient might be having a liver disease or bile obstruction. And at times also you'd want to think about excessive hemolysis. It also give you the yellow pigmentation in a patient. And lastly, when it comes down to the nails, and this list is not really exhaustive, whenever you're having like spooning, think of iron deficiency, probably due to excessive phytate intake. In terms of combination of the foods the patient is taking is what is leading to the iron deficiency in the patient. So you can be able to advise accordingly whenever now you move on to the next form of assessment. It comes to the diet and find out in terms of how is the diet structure here. Moving on. So in summary, what are we saying? So in summary, we are looking at nutrition focused physical examination, which is a very, very essential component of the nutrition assessment. And it usually assists us to identify probable nutritional problems like the nutritional related deficiencies, identify malnutrition in your patient. You are able to elicit scenarios whereby weight loss can be masked, and be able to, and it helps us mostly to determine the appropriate care plan and interventions to institute after you getting your findings in your examination. So it gives you a roadmap in terms of where next. Thank you very much. And the floor is open for questions.
Thank you very much for that beautiful presentation. We had a very in-depth look into what nutrition focused physical examination is all about. And as you can see, it's quite an interesting topic. And what I would say is that for nutrition dietetic professionals who are managing patients in clinical setting, these are topics that we require to understand very well. We need to move from old tradition of depending on anthropometrics, because even most often in clinical setting, we have patients who may not, it may not be possible to weigh them. Like if you have a patient in critical care unit, most of the facilities we have, we might find that we have we are in resource limited setting. And that doesn't mean that you cannot make proper decision in patient management in terms of when you are coming up with a nutrition intervention. So what we are seeing is that when you are doing a component of nutrition focused physical examination, basically you are trying to, that's the subjective assessment. And what it means is that you are looking into what is the nutrition status of the patient. And you are interested in checking on loss of muscle mass, loss of body fat or subcutaneous fat, and also presence or absence of fluid overload, and even ascites if it's present. So you remember very well, these 5 components you need to triangulate so that you can have a clear picture of what are the issues the patient has, so that you can be able to move to the next step, whereby you are supposed to derive a nutrition diagnosis. And remember, nutrition diagnosis is different from medical diagnosis. This is what a nutritionist or dietitian profession can be able to troubleshoot, can resolve, or can attempt to alleviate with a problem. So thank you very much. And we are looking at the QA number of questions. Please keep your questions coming. I've tried to answer one. There is someone who asked, what are the 5 components of nutrition assessment? And we have, there is a posting, but perhaps I can be able to recap again. We have client history, we have food and nutrition related history. This is formally what we used to refer to as diet history. Well, we have biochemical data, medical test and procedure, and this is what we used to call lab assessment. And this is very important. We'll come, because these are series, we come into each of these components and discuss them into details. And then we have what we have covered today, that is nutrition focused physical examination. And then we have anthropometric assessment. I can see another question there, phytid containing foods. Remember, phytid containing food, these are foods that are rich in phosphorus. And basically what you realize is that all protein foods, whether plant or animal proteins, are rich in phosphorus. And also we have cereals. So we have cereals, we have all plant protein and animal protein. But plant protein, they are phytid, and that is a storage form of phosphorus in plants. But if you are talking about phosphorus, we have animal protein also, but in a different form. So I agree, you can help me to respond to one of the questions here. We can see Ms. Warendo, welcome. Excellent presentation, congratulations. Okay, so the question here is there any significant difference in terms of grading of edema in a malnourished patient versus a patient with fluid overload? Okay.
Well, thank you for that question, Madam Morenzo. Well, you see, a patient can have fluid overload and still not exhibit edema. Because whenever you're exhibiting edema, at times it's just because of the fluid shift. And then the other bit is in terms of edema, the grading, there's no difference in terms of how you grade a patient with edema. As long as the patient has edema, the grading will still remain the same. But a patient can exhibit fluid overload without exhibiting pitting edema in the patient. Because at times a patient would, let's say, for example, a patient might be having congestive cardiac disease, or you might be having ascites. So whenever you're having ascites, you see, if you're having ascites, you can't be able to clearly see the edema bit of the ascites, but the patient is having probably might contribute to the fluid overload in the patient. So even when it comes to now the grading, this is grading purely for edema. It's not grading for fluid overload per se. If I can be able to respond, hopefully I've been able to answer the question. There was someone else who was asking about, if I can be able to get the question, they were asking about things to do with the 5 categories. Is there a specific order in which to go about the 5 categories, like which is the first and which is the last? To me, the way I put it is the first and probably the second are the most important ones, which the first we've already concluded is supposed to be the client history. Because the client history gives you more context, what you should be focusing on, what your NFPE should focus on per se. Because if he's having other comorbidities with him, it's good for you to know that. So that now, even as you're doing your assessment and as you're trying to sort of triangulate which other form of assessment will become appropriate, it becomes very handy. So client history should always be the first thing you ever do, followed by the examination, the nutrition focused physical examination. Those two should go hand in hand. First, client history, then nutrition focused physical examination. Then from there on, the rest can follow if they don't have any particular pattern or order they can be able to follow. Because I'd already elicited in terms of perhaps you don't even have a weighing scale. You see, how do you go about it? Or perhaps you see, nutrition focused physical examination has shown you this particular patient is having ascites and probably is having the pitting edema. So in as much as even you're going to do your anthropometry, the way you're going to interpret those readings, it will be more of a monitoring parameter rather than more of an indices for you to calculate probably perhaps body mass index in that particular individual. So the key thing is the first 2 steps, which will inform the rest of the other forms of assessment that you're going to have. Thank you.
So there is somebody asking, is geographical tongue a sign of any nutritional deficiency?
Well, it could be. It could be, because geographical tongue could be as a sign of probably micronutrient deficiency, perhaps zinc, folate, or vitamin B or vitamin B6 or B12. And the other key things, remember, I've also said in terms of not all or everything that you're going to see, it will be deficiency. But it is good when you're investigating, as you're looking into it, you also try to look at now the markers. You can be able to do now the biochemical parameters, since now to focus more on particular micronutrients of key interest for you to find out, are they having a deficiency in it or not? So that you can be able to pinpoint it's a micronutrient deficiency, or is it because of other causes which are non-nutritional?
Now, Lillian Mutua is asking, do you have the explanation of how community can examine for the same? Maybe if I can take that, you realize that the idea around prevention, nutrition as a preventive entity, the universal healthcare agenda was actually aiming at empowering communities to be able to take charge in preventing macronutrient or related deficiencies that actually, if they are not addressed on time or in time, then escalating to serious problems long term. So in this case, you find that with capacity building to the health workers in the community, and I suppose possibly leveraging on the work of community health volunteers, then this element of early screening detection can be well articulated. So it's about capacity building, so that now it can actually be flagged out early and targeted interventions put in place. So do we have lay definition in targeted communication for public literacy? I think still it's tied to the first question around if we go the prevention way, therefore it means with resources, advocacy, and community outreach campaigns can actually be able to help us address some of these issues in time. Another question is what will happen to your body system if you lack vital nutrients in your body, and how can you manage it?
Well, as you can understand, your metabolism and also in terms of whenever it comes to metabolism, micronutrients become very key in this aspect of controlling the metabolism. Because remember, some of the micronutrients act as cofactors to enzymatic activity within the body. So whenever you're having a deficiency in them, it definitely translates to compromising on the metabolism of the patient. And also some of the micronutrients also play a big part also in controlling, let's say perhaps insulin sensitivity, things like selenium or chromium. You see, they assist in the sensitivity of glucose, insulin to go into the cells. So whenever you're having this micronutrient deficiency, it has a plays a very big role in terms of metabolism of the patient, and even the other key things, activities within the body. You see, like things to do with the clotting, blood clotting, there's an aspect of vitamins, vitamin K, perhaps that comes in. So the question was about, will there be an effect? Yes, definitely there's going to be an effect, of which you have to be there to look out for it. So what you're not, if you're not actively looking for it, you're not likely to see it. But if you're actively looking for it, you're likely to get it, or you're likely to see those things, especially if they are presenting there in the patient.
Okay, so thank you very much. I can see other questions following. When we'll cover the other three components. We have just done client history and nutrition forecast, physical examination. So someone is asking when will the rest of series be run? Perhaps Eric, you can be able to give some insight on this.
Well, we intend to have these webinars run at least once a month, and therefore in due course we'll actually be communicating our schedule of events. And given that those of you who registered, you'll actually be receiving email prompts on the upcoming CMEs, so that now you can be abreast with the activities that we shall be conducting. Thank you.
Okay, thank you very much. I think, I don't know whether there is any other issue. Some more comments. So I'm trying to check from the chat if we have any unanswered question. Oh, there is a comment here, talk about CPD points by KDI. Eric, please, you can quickly respond on that.
I think for the nutritionists in attendance, we are in lesson with KND about the award. So we'll get back to you through your emails with which you registered. So, and that is what you'll use to upload to your individual portals on the KNDI website. Thank you.
Well, I can see there's someone who's asking, is nutrition physical examination easy to identify in all types of patients? I can assure you, nutrition focused physical examination is not as easy as I've presented it. Asking, number one. Number two, you have to have the technique of how to do it. You don't just go into, there's the other nitty-gritties which I probably skipped in terms of, you need to prepare for nutrition focused physical examination. You need to prepare the patient also. You need to observe the IPC measures, that is infection prevention control. You need to introduce yourself. Who are you? What are you going to do? Why are you going to do whatever you're going to do to the patient? And you also need to sort of like, why is it important for you to do it? So that now the patient can be able to, and you need to also ask for permission from the patient. You need to seek consent from the patient. If it is okay for you to go ahead and do, so that now they give permission for you to to go ahead. It's not like it's something we just get a patient and then we just move on and do it. So there's the other aspect which I probably skipped, so that now we focus more on the inner details, but it is not easy to do it. That's number one. Number two, it means, as you can see, I'm trying to condense the information so that it fits within the presentation, because there's quite a lot about micronutrient deficiencies that you should be looking into, which I'm not really touched mostly on. I've just provided a summarized table there, of which we need to be key in terms of what we are looking into those key areas. Because you see, the key bit of observing is easy, palpation is the other thing. How should it feel like whenever you're doing the palpation? You see, even the other bit in terms of, at times you get like a patient has had an abdominal surgery, then now you will see people are saying you're waiting for bowel sounds, so you're waiting for bowel sounds. So the other aspect is, what would bowel sounds communicate to you? What would bowel sounds communicate to the surgeon? Would it communicate the same thing as what it communicates to you, perhaps? And actually, what are bowel sounds? You see, those are now the other key aspects in terms of, you have to be well informed for you to be able to go into the nutrition focused physical examination, which is something we need to focus more on. And we need to probably try to practice more, so that now we can be able to assist our patients holistically whenever we are managing them.
Yeah, Naomi Njenga is asking what deficiency can cause the pigmentation spots, especially on the legs. So I think by the spot I'm saying, there are no deficiencies that are actually targeted to the distal, but rather in this case, I would actually advise you have a session with either rheumatologist, say a dermatologist, so now actually, because some autoimmune conditions actually could actually have an implication towards that depigmentation issue. So not necessarily nutrition related. Thank you.
Well, but for nutrition related, you always be thinking about vitamin C, vitamin K deficiency, or perhaps if it is so extensive, the depigmentation is so extensive, perhaps it might be even excessive use of vitamin E in that case. But I'm not saying that could be the problem per se. As my colleague has already said, it should be good for you to seek medical advice from the specialties, especially dermatologists, so that now we can be able to look at into, even in terms of the medication can also be part of those key things that are giving you those side effects. Because you might be having another medical issue to do with thrombocytopenia, perhaps, or the anticoagulant therapy. So there are various causes to it, so it needs to be investigated. So you can't really conclude with this nutritional deficiencies that is causing it, but it could.
Okay, thank you very much. I don't see any more comments, and we appreciate your comments. And for this reason, we'll meet again. We shall publish when next we shall have our webinar series. So keep checking, and we would like to stop at that bit. Thank you for sparing your time to listen, and I hope we have gained some insight, and more is coming. Please be prepared. There is a lot in the house, and we would like also to request you to spare some time when we advertise our webinar series, so that we can have a great forum and we can be able to keep ourselves abreast with new developments such as this. Otherwise, I wish you nice moments. Until next time, bye.
Okay, bye.